Lung transplantation. General guidelines. Any patient less than 65 years old with end-stage pulmonary disease in the absence of other significant organ dysfunction should be considered for referral for lung transplant assessment. Other criteria include the following. Medical therapy is ineffective or unavailable. The patient is experiencing substantially limited daily activity. The patient has a limited life expectancy, usually less than 2 or 3 years, without transplantation. The patient is ambulatory with rehabilitation potential. The patient's nutritional status is acceptable, usually 80 to 120% of ideal body weight. The patient has a satisfactory psychosocial profile and support system. The patient has normal left ventricular function. The patient has a creatinine clearance greater than 50 ml/min. The patient is seronegative for hepatitis B and C, and HIV. The patient is not osteoporotic. The patient has been free from malignancy for over 5 years. The patient has been a non-smoker for 6 months. Indications. Common. Chronic obstructive pulmonary disease. Emphysema due to alpha-1 antitrypsin deficiency. Cystic fibrosis. Idiopathic pulmonary arterial hypertension. Eisenmenger's syndrome. Less common. Bronchiectasis. Sarcoidosis. Lymphangioliomyomatosis. Pulmonary Langerhans cell histiocytosis. Note that where there is concurrent cardiac disease, as there is in many of these patients at this stage, heart-lung transplantation is necessary. Contraindications. Acutely ill or unstable clinical status. Uncontrolled or untreatable pulmonary or extrapulmonary infection. This does not disqualify patients with airway colonization. Uncured malignancy. Significant dysfunction of other vital organs. Significant coronary disease or left ventricular dysfunction, unless heart-lung transplantation is considered. Active cigarette smoking. Drug or alcohol dependency. Unresolved psychological problems or non-compliance with medical management. HIV infection. Hepatitis B antigenemia or hepatitis C infection with histopathological evidence of liver disease. Types of transplant procedure and age limits. While strictly speaking there are no age-based cutoffs for transplantation, organs are of course severely limited and hence priority is always given to those recipients most likely to enjoy sustained benefit. Single lung transplantation, 65 years. Bilateral lung transplantation, 60 years. Heart-lung transplantation, 55 years. Transplantation of lobes from living related donors. Practical details. Preoperative. Ideally the patient should be on as low a dose of corticosteroids as possible. Bridging strategies such as target therapies for pulmonary arterial hypertension and non-invasive ventilation are of value. Ventilator-dependent patients have a much higher mortality rate after transplantation. Operative. Surgical details are beyond the scope of a medical text, but it should be noted that organ retrieval, preservation, and assessment are crucial. Previous cardiac surgery, pleurectomy, or pleurodesis increases operative difficulty and risk. Postoperative. Regular follow-up of the patient with careful monitoring, CXR, spirometry, bronchoscopy, and blood tests to control immunosuppressive therapy, must continue for the lifetime of the patient in order to prevent complications and detect them as soon as possible. A sustained decline of 10–15% or more in forced vital capacity or forced expiratory volume in 1 second, FEV1, suggests a potentially significant problem. Complications. Acute rejection. Most common in the first 6 months: fever, chills, malaise, increasing tightness in the chest, cough, and worsening dyspnea. Complicates up to 10% of transplant procedures and accounts for more than 40% of 30-day mortality. The gold standard for diagnosis of acute rejection is tissue confirmation. The sensitivity of transbronchial lung biopsy for detecting acute rejection varies between 72 and 94%. Chronic rejection, bronchiolitis obliterans. Most common between the 1st and 5th postoperative years, dyspnea on exertion associated with a decline in FEV1. Infection. The main cause of early postoperative death due to typical pneumonia organisms, with high incidence of gram-negative rods, Pseudomonas species, cytomegalovirus, herpes viruses, Pneumocystis carinii, Candida species, and Aspergillus spp. Other complications affecting intermediate and long-term survival include drug-induced renal failure, virtually all patients; osteoporosis, in 73%; hypertension, in 66%; neurological problems, in 25%; gastrointestinal problems, in 20%; non-lymphoproliferative malignancies and disease recurrence. Retransplantation. This is rarely performed, 4% of lung and heart-lung procedures, due to donor shortage and the poor medical condition of potential candidates because of other medical problems or complications related to the first transplant.